Thank you to the organizing committee, Dr. Sinclair, and to Dr. Walker. I hope in the next, excuse me, I have to put on my glasses. There's nothing worse than a blind radiologist. I have these glasses on when I'm working. My job in the next hopefully 15 minutes is to enlighten you on radiology AI. And I was going to include entertain, but I went through this slide deck with my wife last night, and she said, stick to your day job. Don't bother with that entertainment part. So I took out the jokes. So my job is to show you what the status of AI and radiology specifically. And as that image shows you there's a battle royale going on right now in radiology between the machine and the human. And as my wife said, she said it actually looks like the two humans are shooting at each other. And she's actually quite accurate in that. There's a group of radiologists who are really pro-AI, and then there's a group of radiologists who are really anti-AI. I'm not going to tell you which one I am. We'll let you guess. But that's what's happening out there in radiology. So let me go to the next slide here. So in 2016, there was a very infamous or famous article that came out in the New York Times by the Nobel Prize winner, Dr. Jeffrey Hinton, who said people should stop training radiologists now in 2016 because AI in the next 5 years, so by 2021, would replace everything that radiologists do. So basically pack up your bags and go home. So that was 2016, and this was probably about 10 years after, radiology, DICOM and digital radiology became widespread. So this prediction was received with much fanfare and also with much disdain, especially in the radiology community. And it really led to a lot of deleterious effects in terms of medical schools in the States were actually looking at this and saying, should we have radiology spots? Students were looking, well, do I want to spend 10 years becoming a radiologist when there won't be a job for me when I get out? Fortunately, cooler heads prevailed. This is 2019, and this is Dr. Curtis Langlotz, who's a radiologist in Stanford. And he penned this editorial in RSNU's Radiological Society of North America in 2019 saying, and he was answering Dr. Hinton's question, will AI replace radiologists? And his response was no, and eloquently he said, radiologists who use AI will replace radiologists who don't. So he kind of put a little disclaimer on there that, we need to adapt and evolve, otherwise we will become extinct. But if we evolve and adapt, we will not. And that's probably more true than the former. So my talk is on the value proposition of AI in radiology. I want to talk about the transformative potential of AI in that it can provide faster diagnosis, increase our productivity, increase quality, reduce the misdiagnosis risk, improve patient management, reduce physical and mental strains, reduce legal and insurance costs. But there are several prerequisites for that. That's where we want to get to, but there are several prerequisites which I'm going to mention. These include here, and this is a non-exhaustive list, but ethical considerations, data privacy is important, equitable access, how can we get this into the hands of everyone who needs it, transparency, so a transparent model development, explainability, this means can we describe what this AI program, what this computer is actually doing? And that's a hard one. Peer review, we need to always be up to speed on peer review and not using ChatGPT to do that peer review. Collaboration, can we work with our colleagues in various fields, whether it be other physicians, scientists, ethicists, and develop this program? And cost is always a consideration. Most importantly, it's trust. Can we trust the program? Can the patients trust us? Do we trust each other in implementation? Do we trust our healthcare leaders to do what's best? So that's really an important prerequisite. I'll touch on a few of these. First is AI ethics, and this is a PhD lecture in itself. Dr. Chubanidze we were fortunate enough to have her as a guest speaker at one of our AI and radiology lecture series, which we hold quite often through our department. And her talk is actually online, so people want to go to the Queen's Radiology website and download it. It's there for viewing. And she did an excellent talk on AI governance specific to radiology policy and ethics. And she's in Europe, Georgia, Europe, and Europe is much further advanced than the US or Canada in terms of AI regulation and governance. And I'll skip some of these slides because in the interest of time, but there are essentially three areas of ethics specific to radiology which we need to pay attention to. First is data ethics, algorithm ethics, and of course usage ethics. How are we going to use this? Who's going to be responsible for implementation? Where does the liability lie? And the code of conduct. So are we there yet? No, we are not there for AI and ethics. It's a work in progress. What we need to consider is human autonomy. The decision makers have to be humans, not robots, and those humans with sincere intentions. Our focus should be on do no harm, fairness. This should be available to everyone who needs it. We need to be able to explain the program, the data, the analysis, and transparency, especially to our patients. A little bit more into transparency. It's an important prerequisite. We would never buy a car without a test drive, right? Or looking at the details and all the options. So I think that's the analogy that suits us best when we look at an AI application. Transparency matters, and this is an FDA Digital Health Advisory Committee who looked at this, and a patient advocate shared her experience of receiving a mammogram, and the results were flagged by enhanced breast cancer detection software. So if you look at, especially in the States, they put this disclaimer at the bottom of their reports. This is reviewed by an enhanced breast cancer detection software. So what does that mean? Can you explain what that means? 91% of patients want to know if AI is used in their care decisions. So the committee emphasized the importance of informing patients not just if AI was used, but also how it contributed to their care. And who's going to explain that? It has to be us. So transparency builds trust, and patients deserve to understand how AI impacts their healthcare decisions. Another speaker in our AI lecture series is the individual on the right, Dr. Errol Kolak, and he's an AI scientist and radiologist at Unity Health in Toronto. And his main area of expertise is data quality. And this is from him. And so these are CT head scans from 6 different patients. And you don't need to be a radiologist to know that the image on the top left is a nice quality image. The other 5 are from ICU patients, probably Dr. Maslow's special. So obviously one is high quality, the others are not. But they're all patients. We all have to come to a diagnosis and inform Dr. Maslow of what we think. Well, we put these 6 cases to an AI machine, and guess what's going to happen? It's going to give us a great answer for the first case, the one with the high quality. The other 5 is going to say the data is insufficient or non-contributory or some sort of excuse like that. So we really have to be mindful of what we're giving to the AI machine and recognize that data quality is extremely important. Are the performance metrics relevant? These are additional questions that we need when we're looking at data quality. How robust is the validation process? Now, I'll mention validation in a little bit more detail. How will bias and fairness take into account? Is this going to be acceptable to the patients and to the end users? Other metrics, is there a clinical benefit to this AI machine? Are there costs and savings? What's the safety profile? And of course, is there going to be user acceptance? And the users are not just radiologists, but Dr. Maslow in ICU, the patients, the healthcare system. Validation. So this is really important. And validation in AI, radiology AI, is a little different than for drugs, for example. So if you look at the top row, there's 10 patients there, or 10 data points. Validation in AI is usually an internal validation, and where the training subset is 6 of those, and it's validated on 2 additionals. And then it's tested on 2 additionals, but they're all the internal patients. So that's a little bit different than what's done in a more robust validation process, which also includes an external validation step. There are some studies which undergo external validation, but they're typically much smaller than the internal validation studies. And obviously this is done in the interest of cost, time, and availability. A lot of these AI studies are done in silos. So for example, they're done at Harvard, they're done at Stanford, and they're looking at their internal data and then extrapolating that to what you think might happen in Africa or Europe or Canada. This is an analysis of 4 chest X-ray AI studies, and I've circled the red boxes on the right. You don't need to need all the numbers, but essentially what this says is that internal validation shows you great results. But external validation, which was done on the other 3, showed that this chest AI app, which was looking for pneumothorax and pneumonia, did not perform as well. Here's a meta-analysis of multiple AI validation studies. And as you can see in the highlighted red box, the external validation was not used in 94% of studies, which means that only in 6% of studies, in AI studies in radiology, and there were over 500 of them, external validation was not used. So that's important to know. Randomization is also a problem in AI studies. Most studies are non-randomized. In one meta-analysis of 81 studies, only 6 were really randomized. Data access is an issue. Data access was only provided in 5%, so outside sources were only able to access data in 5% of the time. High bias risk was identified in 72%. So these studies are limited. Retrospective versus prospective. So this is another issue in AI and radiology. And we're not immune, so I've highlighted in the box Rapid AI. This is a really neat acute stroke AI software package that we have at KHSC. And we've had it since 2019. We were one of the first centers in Canada to have it. But surprisingly or non-surprisingly, it's a not retrospective AI tool. It was formulated on only 336 cases from 5 sites. And right now it's used all across North America and Europe. If you go to any major stroke center, you'll have Rapid or an equivalent of Rapid to look for acute stroke findings on the CT head. So, but we have to be aware that it's formulated, its genesis is only a small number of patients, a small number of data. Bias is a big issue, not just in radiology, of course, but in all of medical research and healthcare. Specifically, I just want to mention geographical bias. This is a table outlining some of the major sites for training clinical machine learning in radiology. And as you can see, the top 5, 6, 10, actually they're all in the States. I've highlighted Connecticut, that's with my alma mater at Yale. And if you look at the population at Yale, it's people with great insurance, usually Caucasian males and females, and not really representative of the population as a whole of the States, Canada, or of the world. But these are the apps that are generated from all of these sites and then marketed throughout the world. Can we rely on the FDA? I'm being a real Debbie Downer right now. I promise you it's going to turn positive. Can we rely on the FDA? Well, no, we can't actually. If you look at the AI apps that are out there, that are marketed, that are commercialized, they've gone through that process of validation within months, and FDA approval within months, and Health Canada approval usually within 9 months after an FDA approval. The RSNA and the American College of Radiology put out a statement that is we believe it is unlikely FDA can provide reasonable assurance of the safety and effectiveness of autonomous AI in radiology patient care without more rigorous testing, surveillance, and other oversight mechanisms throughout the product lifecycle. It's a very powerful statement saying, basically, you're on your own. FDA approval does not mean that it's a great product. All right, so those were some of the prerequisites. What are some of the potential barriers? I think we all know some of these. Trust and interpretability. Do we understand the product? Clinical integration is huge. Will it fit seamlessly into our workflows? Will our physicians, our administrators, our patients be able to work with this in a seamless fashion? Usability, do we understand what's going on? Or is there a number I can call my IT department where are they going to be able to fix things if things break? Who knows how to use this? Surveillance, are there upgrades? Who's going to monitor that? Who's going to pay for that? Things will break down? Who's going to fix it? And cost. I don't know if Dr. Pecora is here in the audience. I don't see him. But Dr. Pecora has endless amounts of money. So cost is not an issue at KHSC, but it is definitely a concern and a potential barrier. But, you can say barriers, what barriers? Because in China, and this is a news article from last year, China just announced the world's first AI hospital. And it's a revolutionary milestone that has emerged with the unveiling of the world's first AI hospital called Agent Hospital, developed by researchers from Xinjiao University. The virtual medical professionals autonomously evolve their expertise, offering a novel approach to patient care, medical education, and healthcare efficiency. So, in some places of the world, there's limited barriers. So I'm going to conclude by the future, and this is where I think there's some positive spin to this. This is a futurist who we had give us a talk on our AI and radiology lecture series, Mr. Richard Watson from London. And he really gave a lot of insight on what he thinks the future of radiology and AI is. And he talked about the hype cycle. You've all seen this hype cycle for everything. There's a hype cycle for radiology AI, and all these data points are different parts of the AI life cycle. And in his opinion, we are at the late upslope of AI. So we're really at the AI augmented part of that life cycle. And he says we're in for a crash. We're in for we're getting ready to go down that downslope where, where reality will hit the road and we will see exactly what AI is all about. He showed this underground map of London. So this is the tube of the subway system, and it's ubiquitous. It's everywhere. He likened this to AI. AI is everywhere, if not now, but soon. For example, it's in the financial industry. You can see on the right the different colors are talking about the different industries: insurance, transport, media, energy, security, retail, and of course, healthcare. His take-home point was AI is here. We can either do what's needed to coexist or surrender and he said go colonize the moon or something, escape. So what is the future role of radiologist? Here I turn to my friend from Stanford, Dr. Elizabeth Hawk, who gave a wonderful talk on a future role of radiology. And this is from her talk, and it's really, really neat actually, the evolution of radiology. So if you look on the left, 1900 is when radiology started, and then the future on the right. And so X-rays, ultrasound, MRCT, digitization, the death of the X-ray film, which is not really true. We still use X-rays. The voice recognition software came, and guess what? That demise of the transcriptionist. Poor transcriptionists no longer exist in radiology. That happened around in the late 1990s. CT usage skyrockets, so CT use is rising exponentially still. And then the art of the physical exam are forever lost. So I don't know if that happened before CT usage, but it definitely is happening now. AI came in, and then the end of the human radiologist, according to Dr. Hinton. We're still waiting for that, but it's possible. And then finally, AI takes over and ends the human race. So that's on the right. By the way, anyone here is my interactive portion of my talk. Anyone know when KGH or Kingston got its first X-ray machine? No? A little bit of history? No one? It's actually before 1900. So this is not actually correct. It was 1896, literally only 2 months after Röntgen discovered X-rays or described the X-ray discovery in Germany, that the Royal Military College obtained its first X-ray machine. So we were ahead of the curve back in 1896, and perhaps we're close to the end of the curve now. So Dr. Hawk, went on to talk about the future, and one of the points here is what we have to understand: what's the role of the AI companies? What is their role? And it's all about the money, of course. And to do that, their product needs to be valuable. It needs to be valuable for the radiologist. It needs to be valuable for the hospital, for the healthcare system, and of course the patient. So what does valuable actually mean? So that's the big question. And valuable means different things to different folks. So can AI be as good as radiologists? So this is very ubiquitous in the radiology community. You may have seen pictures like this or the other. So I'm not a dog person, and I'm not a blueberry scone or muffin person. I like donuts. But can you distinguish the dog from the scone or the muffin in these pictures? And you'd be surprised how poorly AI does in this, right? I think we can all do it. If I leave this up there for 5 seconds, you can all do it. We'll all be probably 100%. But AI, for some reason, this task, they have a fit. They can't do this. However, they can do this, Brain GPT. So this is really new, like hot off the press. Brain GPT. This is a study of 18,000, close to 19,000 brain CT scans in Alzheimer's patients. And the AI software got a hold of these scans. This is from Taiwan, and both internally and externally validated the study. And this model was accurate in 74% of the time in terms of formalizing a radiology report that was acceptable as diagnosis on these 18,000 plus Alzheimer's brain scans. So it's there. Breast AI is a huge growth area. It has received a lot of attention. If you can solve the breast AI puzzle, you can solve the radiology puzzle, because breast, especially mammography data, is highly intensive data. Lots of bits and bytes, billions and billions of data points go into each mammogram. And if you can do that, you can do anything. This is I was talking about randomized, non-randomized study. This is the world's first randomized control study from Sweden, looking at 105,000 plus patients in a screening program, breast screening mammography program. And it showed excellent outcomes. So the AI software replaced 2 radiologists in Sweden, and in other parts of the world, 2 radiologists look at each mammogram. In Canada, the standard of practice is only 1 radiologist, because we don't have 2, we only have 1. But in the States, for insurance purposes, and in Europe, 2 radiologists have to look at each mammogram before it's signed off and finalized. This AI-supported screening strategy was better than the 2 breast radiologists. So it detected 6.4 positive cases of cancer out of 1,000 patients, compared to 5.0 that the humans did, with only a small, non-significant increase in the recall rates and false positive rates. So very, very powerful study. And this has really changed the landscape, like literally right now in Europe and in States, for breast mammography screening. And what's happening now, as we speak, insurance companies are looking at this, and guess what they're saying? Why should we pay a hospital to hire a radiologist when we can put in this program? We'll buy this program for you. You install it, you'll get a better result, less insurance costs, less expenses in your hospital, and less claims for missed cancers. Furthermore, this study showed that there's a 44% reduction in screen reading workload for the radiologist, so makes the radiologist happy as well if they still have a job. So who decides, who makes all these decisions? Who decides whether to buy the AI software? Is it the department? Is it the hospital? Is it Doug Ford? In England, NHS is one of those entities. And for example, they just, or in 2021, they purchased a HeartFlow, which is a cardiac CTA analysis AI package for all cardiac centers in England. And I mentioned HeartFlow because we are now at KGH about to, we've purchased it through a donor, and we're about to launch the HeartFlow analysis. We'll be the first center in Canada to have this AI software for cardiac coronary artery disease. Medical legal issues. So here's some important points for radiology AI because we don't really understand what's happening. It's all happening behind the scenes in a server, in a computer. Who owns it when things go right? And more importantly, who owns it when things go wrong? So who's going to take the liability? Whose name is going to be on the bottom of the report? Is it going to be the radiologist? Is it going to be Dr. Pecora? Is it going to be the Siemens or the GE of the world, whoever owns the AI app? Whose name is going to go out there? So here's the future. The future is not radiology, right? It's going to be some sort of other ology. So the future, in my opinion, is not a replacement paradigm. So AI is not going to replace radiologists, but an augmented one where human expertise and machine intelligence converge to derive precision medicine, elevate patient care, and redefine the role of the radiologist. So the future department will not exist as per se. Instead, there perhaps will be a medical informatics department that is comprised of physician specialists such as radiologists, pathologists, laboratory medicine folks, engineers, data scientists, computer programmers, and of course, ethicists. So how will radiologists survive in this environment? We must be leaders in innovation. We must always focus on what the clinical problem is. Will the technology address that clinical problem in a logical manner? And what is the impact on the healthcare team? And of course, how will this affect the patient experience? So we all know these two symbols, caduceus and asclepius. These two symbols used to mean different things. So the caduceus was an ancient symbol of trade, thievery, and commerce, actually. And only in the early 1900s, it was used by the American and French armies in war as a healthcare symbol. And Asclepius is the son of Apollo, and it has always been associated with healthcare, but two different meanings. So as radiologists, will we choose to let the virtues of trade and commerce guide our practice, or will we stay true to the essence of healing? And final question, as we face the growing struggles of AI, how will we grapple with the modern difficulties? Will we choose to embody the merchant or the healer? Thank you very much.